Hello and good evening, everybody. Isn't it great to be here? I'm Susan L., Executive Director and Vice President of the Foundation for Barnes-Jewish Hospital. We're so thrilled to see you here tonight, and we just have a fantastic program, and I know that's why you're here. It's an exciting night to be in St. Louis. There are a few things going on. Mostly leading-edge medicine with our very own all-stars. And I promise you, this is going to be just as riveting as whatever's going on at the stadium tonight. And we'll keep you posted, though, as we get news about the game as that moves along. So the real reason that we're able to be here tonight to talk about innovations in orthopedics is because of the philanthropic support that has been so faithful over the years. Through your generous support and that of others, you're helping, through the foundation, you're helping make the best care possible and helping really advanced treatments and care for all of our friends and families. And I have the really easy part of the evening. I don't have to know how to do these orthopedic surgeries, but I get the privilege of making some introductions. And I would like to say thank you to the Barnes-Jewish Hospital Auxiliary. We have several members of the auxiliary. They are sponsoring this evening. And they have on yellow name tags. Members of the auxiliary, would you stand so that we can thank you and recognize you? Look at your name tag, see if you remember things. Thank you. Thank you. And we have several members of the foundation board who have black name tags, ribbons on their name tags. Would you please stand? We appreciate your leadership. Thank you, thank you, thank you. And so now I'm privileged to introduce, and I'm really in trouble if I try to do any kind of sports analogy, so I'll just call them our two team captains. And first of all, that is Bob Cannon, the president of the hospital and president of the foundation. Bob Cannon.
Well, thank you, Susan, and good evening, everyone. Thanks so much for being here tonight. This is really a terrific panel that we're going to have and set of conversations. As we're talking a little bit before the event, before we got started here, it's amazing how many of us, including me, have availed ourselves of the service of them, and how many times it's more than one of them. We've had to avail ourselves of their extremely professional services. One of the best stories I have is having been a runner for many years and experiencing some back pain. I had an MRI, an image done, and I was with one of our panelists, who I won't call out, but she pointed to the image on my MRI and said, "Do you have any pain in that particular location?" I said, "No, it's really fine. Everything feels good." She said, "Well, in a couple years, you'll be back for the pain in that location." So the expertise that we have here is really something tonight. The foundation, Foundation for Barnes-Jewish Hospital, really has been fortunate in the generosity from the St. Louis community and beyond to provide resources that allow us to extend into the research and development of breakthrough treatments for diseases and afflictions that affect us all. And last year alone, the foundation awarded nearly $25 million in support of various research activities. So one of the big messages is to know that what you do to support the foundation and the community has a very real impact on affecting lives of those who face the consequences and the challenges of disease and injury. So really important work. So tonight there's really going to be a terrific panel. We will have a number of experts as we go through the evening who will talk to you. There'll be opportunities at the end for some conversation as well. So please enjoy this. It's really a special treat. This is truly a panel of international expertise and renown that we have here tonight. So it is my privilege and joy to be able to introduce Trish Lalo, who is our president at Barnes-Jewish West County Hospital, and she is going to continue with our program. So Trish.
Thank you, Bob. Good evening, everyone. I have the honor of welcoming to the stage the chair of Washington University Orthopedics, and our moderator for this evening, Dr. Regis O'Keefe. Now, I love sports analogies, so I'm gonna go with them, Susan. I'm sorry, but I've had the privilege of getting to know Dr. O'Keefe over the last few years, and I've come to appreciate that he's a triple threat. So he is a skilled surgeon, he is a visionary leader, and he is a champion of innovation. And we are so fortunate, for those of you that have been to Barnes-Jewish West County, to have his winning team delivering orthopedic care at our hospital. Some of you may know already that we are in the midst of building a full replacement hospital for our campus, and we are very excited that this new facility will allow his team of champions to deliver on that innovation, all in the name of improving patient outcomes and improving the quality of life that we all enjoy. And so with no further ado, I'd like to welcome to the stage Dr. O'Keefe.
Well, thank you very much. First of all, I'd like to begin by thanking Dick Miles and the Board of Directors for the opportunity to be here this evening, and the partnership that you have with the hospital and the programs there means so much to us. Susan Allen, the Executive Director, and the Foundation have been terrific partners, and it's been wonderful to get to know them. And I'd like to also recognize the auxiliary. It's very kind of you to host this evening, and we're very happy to be here tonight. So what I'd like to do actually is get my first slide up. So I think there is a slide before that, but the slide before it talks about the fact that what our mission is, and it's pretty simple. It's making a difference. We want to make a difference in this community. Now, my wife and I came here in 2014. Carol and I were in upstate New York. She's working in a law firm now in town. This is an amazing community. And what we want to be able to do is to touch that community in meaningful ways. And I wonder if we could, I'm not pushing any buttons. Can we go back to the beginning of the presentation? Okay, this actually is my first slide. So we're here. So again, this is at the leading edge, and we want to be at the leading edge in orthopedics. I'm going to give you an overview of the entire department. And our goal is to make an impact. And we make that impact the way we can touch lives, the way we can influence care locally, regionally, and nationally, and not only that, internationally. And it's through the partnerships that we have that makes that possible. So I might have to ask them in the back to advance the slide. Okay, so we have a mission that encompasses all these elements. And I'm going to spend most of my time talking about clinical care. But I do want to mention that in education, there's about 160 training programs in the United States. We have 40 trainees. These are the best and brightest in the country. We have 700 applications for our 8 spots. We did extraordinarily well in the match, and we're the #3 ranked program in the United States, which is pretty remarkable for the Midwest. And so we're really proud of that, and we have this long history of education and research. Research the types of things that can make a difference. We are #1 funded in the United States. There's not another program in the United States in orthopedics that has more funding. We've been #1 funded, I think, 7 of the last 8 years. The one year we weren't, I was #1 funded in Rochester, New York. So I'm proud to say that I've been funded, continuous funding now for the last 8 years. And we have remarkable leaders, and you have some of them here, and we'll talk more about that as we go on. So the next slide. So when we talk about clinical care, these issues are important. And next. And the strategy that we have around clinical care is to increase our impact. And there's an explosion of need in musculoskeletal care. When I came into this field in the 1990s, it was a kind of a niche, and I was deciding to out of medical school. I graduated from Harvard to go into orthopedics, it was a small field. It's an enormous field now, and the impact is really dramatic. And we want to have that impact in places like Barnes-Jewish Hospital, Barnes-Jewish West County, where we're building programs, and throughout this community. Next slide. So this demonstrates the visits and the growth of our visits. So next slide. And so this is a trajectory we're on up until 2013 or 14. And next slide. Next slide, yep. And this is the trajectory we're on now. And so if you look back at 2014, we saw 116,000 patient visits. This year we're going to see 170,000 patient visits. So that's a remarkable increase. You know, any business where, and again, many business leaders are here, where you're going to increase the impact that much, that's really remarkable. Next slide. And we do this in part through recruiting just extraordinary faculty members. And it's, again, the support that we have, the ability to build programs, to develop careers, to provide an environment where people can really do our mission, which is make a difference. That resonates. To be great educators, to make a difference in research, to understand better ways to make care pathways. And so this is a remarkable group. I'm also happy to say 25 people are here. 10 of them are women. And that's one of our missions is this idea of diversity and inclusion. Next slide. So this has resulted in a large increase in our staff and faculty over these last several years. Next. And we did this in part when I came. These are the clinic sites that we had. Next slide. Since 2014. And we hadn't really planned to do all this. It just kind of happened. We had so much enthusiasm in the program. There's so much ability to work in this community. So as we opened up sites, we realized there was more and more need and passion for what we did. So we added 56 examination rooms in the last 3 years. And I can tell you that today we saw patients in 148 examination rooms through this community. And that has a remarkable impact. Next slide. And it comes down to patient care. And, you know, one challenge is, and again, with the business leaders here, I'm learning about business as we go through this, and I learned about this in upstate New York, wasn't my training, but you realize as you expand, handling success is a big challenge, right? It's a really big challenge because as you get bigger, how do you stay as good? As you get bigger, how do you keep those intangibles around culture, integrity, communication, collaboration that are so key, particularly when you expand all these sites? And next slide. And we do it through this strategy of commitment, compassion, and with amazing leadership. And this is Diane Griffith, who is really responsible for so much that happens in those examination rooms and oversees the staff. Next slide. And I just want to mention that there's an award called the Apollo Award. It's given for the group that has the highest satisfaction scores. The department at Washington University has the highest satisfaction scores in a given year. We won this in 2017. If you take a look at it, there's a couple of remarkable things. There's a real mixture of people at different levels of staffing. The other thing is there's just tremendous smiles there. You can see people captured in a moment of excitement, enthusiasm about the program. The other thing is the plaque. They handed the plaque to me, but it's not me. It is this staff that really makes the difference. And I think, again, as business leaders, this resonates with many of you that, you know, it's really that staff that connects so much with the community and develop that culture around that stuff. Next slide. So we won this Apollo Award now 8 of the last 10 years. The other departments don't like us very much anymore. Next slide. And as we've gone out to different areas, Chesterfield, obviously, we all opened in 2008, and that had been the highest rated satisfaction scores. And next slide. And I'm happy to say that actually a new site that we opened in 2015 or 16 at South County now has the highest satisfaction scores in the whole system. And that's a new site. So again, we've been able to take that experience, that expertise, but also that commitment, compassion, and connection with patients, really caring about them and the problems. Now we see 170,000 patient visits a year. What we want each patient to think or understand is their visit is the most important thing there possibly is. Next slide. So, and so 12 of our providers were in the top 40. There's 1,000 providers at Washington University, and 12 people in our group were in the among the 40 highest satisfaction scoring physicians or providers. Next slide. And we do things around wellness. This is Dr. Prather, and you'll hear probably more about the Wellness Center as we get into our discussion. So we touch patients in this big global way, but I want to finish with saying that we touch individuals. And next slide. And around that, next slide, I want to just share with you a case that I personally took care of. I took care of it with my colleagues on the stage here, and you'll hear more about that. This is a 9-year-old boy. He presented with a mass in the left arm. He was active, passionate, absolutely passionate about hockey. Came in with his Blues jersey on and so on, and he was not aware of an injury. And I examined him, and he had, next slide, he had a lump. He had a lump. So you can see this extra bone or abnormal looking bone within his bone, and then there's some of the bone growing out. It was a lump. And next slide. And it turned out this was an osteosarcoma. This is a very serious cancer. It very rarely occurs in 9-year-olds. It's really problematic in a 9-year-old because there's so much skeletal growth involved. Next slide. And this shows the MRI scan, and it extended pretty far down in the bone. And you can see it, that white portion where it's extending outside the bone. Next slide. And the challenge about this is it was right by the growth plate. Next slide. And so you can see it's right by the growth plate, and the typical thing to do in the United States around this would be to take out that whole proximal part of his humerus, including his shoulder joint, and he might get a little bit of this the rest of his life. It wouldn't grow, and it'd be a major disability. But again, we're dealing with cancer. But we thought because of who we are, what we can do, and the people we have, and the commitment we have, we could do something different. Next slide. And so with Marty Boyer, who's here, next slide, I was able to resect that bone, that segment of bone, coming very close to the tumor. And again, it was a lot of expertise, my experience in doing this many times. Next slide. And then we could take a piece of vascularized fibula with the vessels, microsurgery, really elegant microsurgery. Next slide. And we could put, next slide, and we could insert that into that segment. And this is what we did in him. I want to show you how this went. Next slide. So this is during the surgery, and I am making the cuts. This is real time in surgery where I'm making the cuts, and I'm right by the growth plate, probably within, 6 millimeters. We talked about, this is a 1/4 inch from the growth plate. So I have to be between the growth plate and the tumor, and there's only a 1/4 inch there. And so I was able to take this out safely in one piece. Next slide. Dr. Boyer came along, and he put in this fibular graft. Next slide. And this is at 2 weeks after the surgery. Next slide. This is the area of the fibula where he had some bone removed. And next slide. And this is Will. And he's wearing a Cardinals hat. So it's really appropriate for diet. Will is a really remarkable, you'll hear him a little bit, I'll give you a little more information, but he's a remarkable kid, and he's permitted us to talk about him, but this is 2 weeks after the surgery. You can see he's smiling, probably one of the few times he's been smiling in the last several months here. Next slide. He does a blog. He's a blogger, and he does these video blogs that are just extraordinary. He produces these things and puts them about cancer, about what he's faced and challenges of cancer and how important it is to support people with cancer. Next slide. And you can see how he's doing usual kid things. And remember, this is a child that wouldn't be able to raise their arm up. They'd have a functional hand, but not a functional arm. They couldn't move their upper extremity. Next slide. And this just shows a recent picture where I took out the screws in the top so they can grow, but the growth plate's intact. That bone has healed. It's gotten thicker, and he is doing great. Next slide. And so this is Will again. He's a passionate hockey fan. He was recognized by the Blues. You see him with some of the Blues here. Next slide. And we'll finish with this is about making impact. So we do it in a big way, the way we try to develop programs so we can make a difference in this community. But on an individual level, it means so much to us personally, myself and Dr. Boyer in this case. We spent a lot of time thinking about this, talking about this, planning this, and when we can make this kind of impact. So I'm going to stop there, and our next speaker is going to be Dr. Rick Wright. Dr. Wright is a Jerome J. Gladden Distinguished Professor of Orthopedic Surgery. He's Executive Vice Chair of Orthopedics. And what does that mean, Executive Vice Chair? It meant that he and myself could meet with Trish Lalo at 6:30 this morning. That's one of the things that, man, and along with Heidi Prather and Dr. Cleese, her vice chairs, and we accomplished a lot. It was a great meeting. Dr. Wright's also the team physician for the St. Louis Blues, so it wasn't a great week for the Blues, but we won't mention that. And then he also is a national leader, major orthopedic society in the United States, the American Orthopedic Association. Dr. Wright is the president-elect, and he will be giving a presidential speech for that society, really distinguished society, in June, and we're assuming the presidency of that society. So he's a remarkable person. So I'm going to invite Dr. Wright to give a presentation. Thank you very much.
So it's either fixed or I have the touch. So Regis, what he didn't mention was that he's the current president of the American Orthopedic Association, so I will take that from him. And Regis saves lives, and as I tell people, I don't save lives, I save lifestyles, or try to. So I'm going to talk a little bit about a big interest of mine, ACL reconstructions, and it's what we call the search for the Holy Grail. So we'll talk about what is an ACL, what's an anterior cruciate ligament, what does an ACL injury mean, why does it really matter, and the research we've done to investigate some of the outcomes of ACL reconstruction. So how many of you know, before I start, what an ACL is? How many have maybe had a family member, read about it, or it's pretty prevalent. Sports medicine would not exist as a specialty in orthopedics if the ACL healed, because that was kind of the impetus for really making a niche, because if everything just healed on its own, it wouldn't have been a big problem. But trying to find a way to treat ACL injuries has been really what has driven the start of sports medicine. So, what is an ACL? So this is a femur. This is a left knee. This is the anterior cruciate ligament, runs from the front of the leg bone up to the back of the thigh bone. Here you can see it from the side, running from the front of the leg bone back to the back part of the femur. Could you back it up one, please? So, it's a ligament. What's cartilage? This is the side cut of a cadaver thigh bone. That's the bone, the white stuff there, like the white stuff on the end of a chicken bone. That's articular cartilage, cartilage on the end of the bone. If you have arthritis, it is damage to that cartilage. Some of you, and I know a couple of you in the crowd, have had meniscus injuries. The meniscus is this soft rubbery bumper cushion that helps spread the contact on the articular cartilage and help protect it and keep you from getting arthritis. Here's a top-down view of the meniscus. Trimming out a torn meniscus is the most common orthopedic procedure in this country. Arthroscopically, the introduction of the arthroscope in the late 70s and 80s really revolutionized that procedure, along with many other sports procedures that we do. So why does the ACL matter? Well, it controls rotational stability. It's required for change of direction activities. So if you want to cut, turn, twist, plant, jump, change direction, you need an ACL. If all you want to do is run, cycle, elliptical, straight ahead work, you don't need an ACL. So when you tear the ACL, which we can see, this is an intact MRI ACL. Here it is, just kind of starts out and then just explodes. Here's an arthroscopic picture of a torn ACL. So when you tear the ACL, you have to make a lifestyle decision. Am I going to not do change of direction activities, or do I want to continue to do change of direction activities? For adults my age, I kind of know what I do and know what I'll do next week. For teenagers, they don't know what they're going to do tonight. So most young people will get it reconstructed because they don't really know the activities they're going to do. There's probably 250,000. It may be as high as 500,000. If you look at some of the industry and the implants we use, it may be as high as 400,000 to 500,000 ACL tears a year. A lot of them are non-contact. That's why you'll see that running back on Sunday afternoon on, not in St. Louis, in LA, cut. Not that I'm bitter, but cut and have no one touch them and just go down in a heap, or you've been watching a family member play soccer, or you may have been playing soccer yourself, and you plant and cut, and you feel a snap and a pop, and your knee gives way. Well, you've torn your ACL. And then the really sad thing is that if you look at equal exposure between males and females, so if you take 2 collegiate soccer teams, male, female, equal hours of practice, equal number of games, females will tear their ACL 2 to 6 times more frequently. So it's really an epidemic for basketball, volleyball, soccer teams for women. It's really a big problem. So that's really sad. There's probably not a female basketball team at the collegiate level in the country that doesn't have at least 1 or 2 of their members that have had an ACL reconstruction. You look at the men's teams, a lot of teams will have no one on the roster that's had to undergo a reconstruction. So it's a big deal to stay active. So once torn, it doesn't heal. So even if I went in and sewed the ends together and tried to do a repair, it doesn't work. And that's been studied in randomized trials. So we've got to replace it, or you've got to decide that you're not going to do that type of activity. So a lifestyle decision, as I had mentioned. So it's a choice for the people that want to remain active. It's most commonly performed with part of the patellar tendon, which is the tendon that connects your kneecap to your leg bone, or the hamstring tendons, or you can use a cadaver in some circumstances. We know it works for short-term stability. Long-term risk of arthritis is probably there with or without the reconstruction at a relatively high rate. Here's how we will do it not infrequently. Here's the kneecap. Here's the center of the patellar tendon where we've cut out the middle third, created this graft. 2 drill holes, 1 in the leg bone, 1 in the thigh bone, put the graft in place, and then we let your body turn it into a new ACL. So here's what it looks at the time of reconstruction. This is an arthroscopic picture of a graft that's just been placed. And here's a picture of the same graft a couple years later, so you can see how it turns into what looks like a normal ACL. So early on, about 2000, one of my mentors at Vanderbilt put together a multi-surgeon, multi-center study, 10 surgeons. I was one of the original founders with them. And we wanted to study through this group that we named the MOON Group, the Multi-Center Orthopedic Outcome Network, the predictors of outcome, and figure out why some people did better than others after an ACL reconstruction. And at that point, that kind of research was fairly novel in orthopedics and especially in sports medicine. So one of the most important things we found is that cadaver grafts, which back then a lot of people would put cadaver grafts in everyone so that you didn't have to harvest any of your own tissue. But what we found is that if you put a cadaver graft in a teenager, so if you take, for example, a teenage female, a 16-year-old soccer player will have a 5% risk of the graft failing if you use their own tissue, but if you use a cadaver, it would be 4 times higher, upwards 20 to 25%, a completely unacceptable rate. So through this study, we were able to convince people to stop using cadavers in young people, except in very rare circumstances. If you take a 40-year-old, it's still 4 times higher risk, but it's a 0.5% versus 2%, so about 98% successful no matter what you use. So you can take somebody, my age in my 50s and do a cadaver, probably just going to be fine because I'm not as active as a teenager, probably don't even need an ACL, but a lot of people still think they do, so I can offer them a cadaver graft. So while we were doing that, we found that the #1 predictor for a bad outcome with a ACL reconstruction was if you tore your graft, which is always going to happen at least some of the time when people go back to activities, we have to do a redo. The #1 predictor for a worst outcome was if we had done a redo ACL reconstruction. So because of that, we decided to break off and develop another group, the Multi-Center ACL Research Study, which we named MARS, because anyone like me, I'll do 10 to 20 revisions a year. Only about 10% of my ACL reconstruction a year are redos. So we needed more than just 10 or 15 surgeons. We needed what we ended up with. We needed over 75 surgeons. So we brought together this group that we called the MARS group and started studying the redos. So we had 100 surgeons participate in training sessions, and currently we're working with over 80 IRB, the Institutional Review Board that approves research studies at 50 sites. It's a 50-50 mix of academic and private practice, so it's a very generalizable group to the rest of the nation. So it's really been fascinating. We are the coordinating, I'm the principal investigator and for the group, and Washington University is a coordinator. Here's a map of our sites around the country, a lot of eastern sites. Here's one of the, I think, most striking things that we found is if you do a first-time ACL, they may have a meniscus tear. A lot of times you can repair it. They almost never have, less than 5% of the time. They'll have any damage to that cartilage on the end of the bone. When you do a redo, less than 9% have normal cartilage and normal meniscus. 90% have either cartilage or meniscus damage. 60% have both. It's really striking how much damage there is in the knee, and we think that, and we've shown that that's some of the predictors for why these people end up doing so much worse. And then here, the biggest question is everyone would stop me because they knew we had the study going, and they'd say, Rick, what graft should I use when I do the redos? Because the patient has typically already had one graft utilized, and more than 2/3 of the time it's probably been their own tissue. So now you're starting to run out of options. And so what we did is that by doing this study, we were able to show that here was the allograft or cadaver group. It's an older group. 28 versus 24 was the median age, and they're less active. This is a validated activity score. So it's a less active group, and they're older. But despite that, they still retore. The re-rupture rate was 3.3% overall, but twice as many allografts as autografts failed. And you were about 3 times more likely with a redo to have a failure if you had used a cadaver. So this was gave us the ability to tell surgeons, do whatever you have to, but if you can, on a redo, if you have the option to use your own tissue, use your own tissue. And this has started to kind of change practice around the country because a lot of us, it's easier on the patient would just use an allograft. I had always tried to use the patient's own tissue, but the allograft, now we know if you can, use their own tissue to end up with better sports scores and, more importantly, less likely to fail. And so how do we do this? I always tell people if you can do one study in your life that changes clinical practice, then you can probably look back on your career and feel like you made a difference or made an impact, as Regis mentioned. So we got this NIH funded with 2 grants over the last 7 years because, as you can imagine, a 80-plus surgeon, 50-site study is expensive, and trying to follow these patients and track them down, it's hard. It's hard work, and it takes people helping me, and the people helping me, they don't want to volunteer, I found. They want to get paid. So it takes a lot of money. So we started with small industry grants, grateful patients, people in the audience, foundation support, and that's what gets us started. And because of the unbelievable culture of Barnes Hospital and Washington University, is that we can pull this off. We can pull off this is the biggest series of revision patients in the history of medicine. If you looked at everyone that's been followed for 2 years in all of the rest of the studies combined, it's 863 patients. We enrolled 1,200 patients alone in our study. So in one study, wiped out all of the results, and it was prospectively done, and so the science is so much better. So it really is, it's a real credit to where we are, St. Louis, the people that help us and have created the environment where we can accomplish this. And I always say there's a couple ways that you can really multiply your impact as a physician. And that's through research and through education. And the support of people like you in the audience allows us to, and everyone sitting at the table, to follow these other passions. So as one physician, if I do 500 cases a year and do that for 30 years, I take care of 15,000 patients, plus a bunch in the clinic, but we're just talking about surgery. If we educate 6 and now 8 orthopedic trainees a year, and we do that for 30 years, and they go out and do 500 cases a year each year, then I've impacted over 2 million patients. And that's how being at a place like WashU and Barnes and with the support of people like you so that we can educate and not have to just crank out the clinical volume all the time and do some of these other things, we can make a difference. And when you can do a study like this and have the support of a department and a university where you can change clinical practice, so 10% of those 400,000 ACLs a year fail, so 40 or 50,000 revisions a year, and now I can tell them what graft to use, I can impact those people's lives. And so it's moments like that that you realize why you do what you do and how grateful we are to be at this kind of place. So thanks for coming tonight. It's great to have a chance to talk to you and to talk to everybody beforehand, but thank you for your support.
Thanks. We're going to have John Cleese come up next. John is the Daniel C. and Betty Veman Distinguished Professor of Orthopedic Surgery. He's a vice chair in the Department of Orthopedics, and he's the chair of Arthroplasty Division. John?
Thanks, Regis, and thanks for the opportunity to talk to you this evening. We appreciate your being here, and we appreciate all your support. I do have a couple videos in my presentation. Dr. Wright recommended I not include videos because they may not work, but we're going to see how it goes here.
He doesn't listen to me.
So we'll take my talk, or is it just the next slide? There we go. Okay. And I am going to show a couple of videos of patients, all of whom have agreed to have their images shown and shared in presentations like this. So how many in the audience know someone who's had a hip or knee replacement, or has had a hip or knee replacement, or has had a friend that has a hip or knee replacement? So we're basically all there, okay? So I think quite clearly osteoarthritis is associated with a major disease burden worldwide, and we live that every day of our lives, individually or with the people around us. So really we now have a critical need for improvements in treatment. And those improvements are going to come through innovation in clinical care and research, as you've heard from the other speakers. So tonight I'm just going to take a couple minutes to teach you a little bit about the normal hip and then about the diseased hip. I'm going to focus on hip dysplasia, which is a very common disorder that leads to osteoarthritis of the hip. And then I'm going to tell you a little bit about our innovative clinical care and our research program. So the normal hip, as you probably know, is a ball and socket joint. The gliding surface of the joint is soft cushion tissue called cartilage, and that's what really keeps our joint healthy. Loss of cartilage is osteoarthritis, and that's what we're familiar with in terms of the affliction of osteoarthritis. Well, let's go back to that. So this is a video that shows a normal hip. So this is a normal hip. We have the ball well seated in the acetabulum. When a person bears weight on the hip, you see load distributed throughout the acetabulum. So that's a normal loading of the hip joint. In hip dysplasia, you see there's a shallow hip socket. When we bear weight on the hip, the load is focused on the rim of the socket. And over years in a patient, this leads to degeneration and breakdown of the cartilage and osteoarthritis of the joint. And again, hip dysplasia is the most common reason that females have osteoarthritis of the hip. And that's a disorder that is present in adolescence and one carries throughout their life. So I'm going to talk about end-stage osteoarthritis of the hip. We have a very strong program focused on hip and knee osteoarthritis. We're also interested in complex replacement procedures. And then I'm going to talk about our work with pre-arthritic hip disease, which focuses on early diagnosis, early treatment, and prevention of osteoarthritis. Our total joint replacement program, we've been working on this now for almost 2 decades. We are one of the premier programs in the country. We have focused on optimizing our patients for surgery, surgical innovation, anesthetic and pain management innovation, rapid mobilization of our patients, short hospital stays, a robust patient education program, and a program that really involves the patient and the family members in the healthcare team. This is one example of how that program has been successful. So when I started practice, patients were in the hospital for almost 5 days, and today our average hospital stay is just over 1 day, and we're now starting to send patients home the same day of surgery. So you can just see that dramatic change in the treatment of patients with osteoarthritis and the evolution of hip and knee replacement over time. We're also interested in very complex replacement procedures, so we're a tertiary referral center for complex procedures. This is a young woman, 18-year-old female from Bosnia. She has severe hip pain, severe difficulty ambulating, and you can see these are her normal hip sockets, and her femoral head is highly dislocated on the side of the pelvis. Traditionally, this patient could not be treated for this hip disease. With innovative clinical care, we're now to the point where we can reconstruct these hips and really return this patient to a more normal lifestyle. So this patient was reconstructed, bringing the hip center down to a normal position, and then a complex reconstruction of the femur to also bring that down to a normal position. So these are her x-rays after both hips have been reconstructed, normal position, complete pain relief, and an excellent clinical result. So innovative surgical care that we really could not provide several years ago. Now we're able to do that in a reliable fashion. So those are just a couple words on hip replacement and knee replacement program. One of our real focus areas is pre-arthritic hip disease. So we're now trying to identify patients at risk for hip osteoarthritis and treat those conditions early to prevent osteoarthritis later in life. The periacetabular osteotomy is a procedure where we reposition the natural hip joint. So we have a shallow hip socket and dysplasia. We reposition the natural hip joint to relieve pain and really to return the hip to a more normal state. This is a typical patient with hip dysplasia. So 23-year-old female with bilateral hip pain and limitation of activities. You can see she has shallow hip sockets, but she does not have arthritis. So these hips are reconstructable. Here she is 7 and 9 years after her surgery. She's had complete relief of her hip pain. She's had 3 children since these surgeries and really has had an outstanding result. Hopefully, we have prevented her from having hip osteoarthritis later in life. Here she is pictured with her mother, who is another patient of mine. So her mother came to me with hip dysplasia, but she had already had a hip replacement that failed, so she needed a revision hip replacement, and then she got osteoarthritis in the other hip and needed a hip replacement. So at a relatively young age, the mother has had 3 hip replacement surgeries. While the daughter, hopefully, we have reconstructed her hips and prevented her from osteoarthritis later in life and prevented the need for hip replacement surgery. This is another area we have special interest. This is a very young athletic patient with hip dysplasia. Traditionally, and even today, this patient will commonly be advised that these hips are not reconstructible, or if we reconstruct them, he will not be able to continue with his sport activity. This is the patient a year or so after his surgery. So both of his hips were reconstructed. So here he is in yellow, number 8. He was in high school when we did his surgeries. He continued his high school career and went on to a full college career, Division I soccer, after reconstruction of the hips. So what about our research program? So that's innovative clinical care. In terms of research, real quickly, we focus on multidisciplinary research teams because that's how we think we're going to make a difference by learning from each other. We emphasize collaboration and interaction, and we emphasize the common goal and vision of curing hip disease over time. Just a couple examples. We have a Washington University BGH hip and knee registry. This is over 13,000 cases where we can study hip and knee replacement procedures, one of the largest registries in the country, and we have a large team working with that registry. We have the Young Adult Hip Research Group, which again focuses on this pre-arthritic hip patient population and is also multidisciplinary. We house the largest multidisciplinary study group in the world looking at hip preservation surgeries, and we have close collaborations with our basic scientists, again learning about osteoarthritis and cartilage repair and regeneration. So bottom line here in conclusion, osteoarthritis, as you all know, is a profound worldwide health problem. Innovative clinical care is empowering our patients and is better than it ever has been, and we're now providing novel solutions for some of the difficult cases that I showed. We now have multidisciplinary teams that hold incredible promise for the future in terms of finding solutions and actually curing hip disease. We really appreciate your past support, your present support, and look forward to continued improvements in the care of the patients with pre-arthritic and arthritic hip disease. Thanks for your attention.
Thank you very much, John. So we're going to move on to panel discussion now. We have assembled here the following group, and next slide. I guess maybe I can try this. So I've Dr. Boyer's here, and I've seen a little bit about what he does. He's a Carol B. and Jerome T. Loeb, and it's so great to see Carol here tonight. Been such a tremendous supporter of the department and a great partner. He's the co-chief of the hand surgery division, and he is the president-elect of the American Society for Surgery of the Hand. This is a group of the hand surgeons throughout the entire United States, both plastic surgeons and orthopedic surgeons. A really remarkable position. So Dr. Boyer is here with us tonight. Dr. Wallowski and maybe Jacob, maybe you could wave as I'm introducing you, or it's a small wave, all right? But he does big surgeries. He is the professor of orthopedics, chief of spine surgery. He is on an amazing trajectory in his career in terms of leadership, doing some incredibly important things in the department with representing us with a hospital around perioperative services. And he's a member of the board of directors of the American Academy of Orthopedic Surgeons, a really distinguished position for someone in an early career stage. John Cleese, we already heard from, and John, as mentioned, is the director of the Anchor Group. This is this young adult hip preservation group. John is a person, he's very modest. He operates on people on a weekly basis from around the world. He was telling me one day, I think out of Barnes, West County, he had a patient from Italy, one from Switzerland, one from England, one from Creve Coeur, and San Francisco. So people from around the world come to see John. So if any of our partners here, and we do consider partners, need to see John, call me, and we'll make sure you get in. Okay, so he's really remarkable. Farsh Gilak, and Farsh is probably the leading investigator in the United States in regenerative medicine and musculoskeletal diseases. He's the past president of the Orthopedic Research Society. He's the past chair of the NIH Skeletal Biology Review Panel, which is the panel that decides who gets grants at the NIH. It's an amazingly important position, one that where you're greatly respected by your colleagues. Heidi Prather is a professor of orthopedic surgery. She's a vice chair in the Department of Orthopedics. She's the director of the Musculoskeletal Physical Medicine program. She's the director of our outpatient orthopedic services program at West County. She's working very closely with Trish Lalo and others around that. And really remarkably, the North American Spine Society has about 10,000 members. Until Dr. Prather became the president, every single person was a man who was a president. Every single person was a surgeon, either an orthopedic surgeon or a neurosurgeon. And we broke the mold. We now have a new future for women in the North American Spine Society, I'm proud to say, and she's an amazing leader, really, truly amazing leader. And then finally, Dr. Wright, Jerome J. Gilliland, distinguished professor, executive vice chair, president-elect of the American Orthopedic Association, and he was quite modest. This grant that he currently is in the second phase of this grant is $3.7 million. So basically, as the community, many of you partnered with him to get this study started. And again, from business, this return on investment's been amazing, and nationally even more so with the way it impacts the people around the United States. So that's our panel. So what we'd like to do, I don't know if there's microphones, if we would like to open it up for any questions that people might have of any of the members. Yes, please.
I was just wondering about stem cell replacement.
Yes.
I've heard a lot about that as being like maybe the next step so that we don't have to cut over things, have
I'm gonna pass this along to the panel, and we're fortunate to have probably one of the leaders who is just as a prelude to that. There was in summer of 2016, I believe, in Google Global Health News, the #1 story in the world was Dr. Gilliland's study about stem cells and using it to create tissue engineering purposes. So I'm going to pass this on to him. He was on the BBC. He was on news across Europe and interviewed on NPR and things like that, national news. So Farsh, can you give us some insights about that? And I think you're using it to try to develop joint surfaces, but again, stem cells and how it can be used even in patients.
Absolutely. So can you hear me okay? Okay. So our laboratory does a lot of work on stem cells and in the broader field of what we call regenerative medicine, which is what cells are supposed to do. They're supposed to regenerate your body. And as you saw from Dr. Cleese's talk, if you can get to someone with arthritis before they have it, you might be able to prevent it. But once you have arthritis, you sort of go from taking Motrin and maybe exercising and weight loss, all of a sudden to replacing your joint with metal and plastic. And what we really want to fit in that gap is what we call regenerative medicine. Can you get your cartilage and bone to regrow itself? And stem cells are the critical element to that. And I think one thing that's important is to define a stem cell. You hear it all over the place. You see it in your in-flight magazine. There's billboards, come get stem cells. Most of what you're seeing aren't actually stem cells. They have a really simple definition. They're a cell in your body that can do two things. It can divide and make two cells, and then those cells can turn into something else. So very simple. So it's basically a cell that hasn't decided what it wants to be yet. It's like a teenager of a cell. And it needs to grow up, and you don't want it to divide necessarily like a teenager. And so you have to tell it what to do. And so for better or for worse, almost all of the stem cell therapies that are being offered now are useless. So they haven't been approved by the FDA. You're almost definitely not getting a true stem cell, and they have not been shown in any kind of controlled manner to have a beneficial effect. So there's a lot of research that still needs to be done, and the pathway isn't necessarily just to take some cells and inject them in your body and hope they go to the right place and do the right thing, because that's sort of been proven not to happen. But the other approach is to take those cells and teach them how to regrow the tissues of your body. So much of what we do in our lab is to basically try to grow the tissues that you just saw from our surgeons showing you what they're reconstructing. We want to grow your own replacement parts in the laboratory. So one thing we've been able to do is, for example, take stem cells, which the most abundant source in your body is actually your subcutaneous fat. So fat is just full of cells that will make more fat if you need them, but if you take them out of your body, you can reprogram them, and they can make cartilage and bone and ligaments and tendon. So we can take those, tell them what shape to grow in, and we've actually been able to grow a hip inside the laboratory, a human hip out of stem cells from fat. So now we're testing those, and if things go well in the next 3 to 4 years, we can actually start testing them in people. So, yep.
Have they been doing this in Europe for quite a while?
Well, there are procedures that are being done. There's a few, and in Europe, they're still doing the same thing, but none of those studies have actually been shown to work. So there's a lot of profit to be made, and insurance companies don't reimburse them because there's no clear benefit. Unfortunately, a lot of the data is from one-off studies, oftentimes, anecdotal. One person who says, "Oh, I got this and I felt much better," and they don't show you the dozens of other people who got it and didn't feel better.
And so let me just finish on, and we'll get to another question. And the question you have is, should I go and get stem cells injected in my knee joint? I know somebody that had that done, for example. What happens is a lot of that happens in small clinics, and because it's your own tissue, someone can take some peripheral blood, they can isolate some cells, and they can put it back in you. That's legal to do that. The problem is it's never been shown to be effective. It's not really been studied. It doesn't have the same rigor that Dr. Wright had and what he's shown in his studies, and it's also very expensive. And when what we are concerned about is it's a vulnerable population, you have a disease, and you are desperate, you want to have something done. This is something you can do. So there's a lot of that done right now, and it's very controversial. We are probably going to start doing it, but we're going to do it different because we're a place that can figure out, does it really work? And how do you actually make it work, and can you prove that it works? That's what needs to be done. That doesn't exist right now. That will transform the field in the way you use stem cells and things that the thing that Dr. Gilliland, there's a picture Dr. Gilliland has of this joint that he produced that was shown in newspapers all over the world. Really extraordinary. So next, I think, yes, question, yes. Yes, sir. Yeah, it is. We could hear you, yeah.
Okay. This is a question that could be addressed to either Dr. John or Dr. Rick. And how important is stretching to maintain the health of one's ACL or hip?
They're debating it up here among themselves. So I think it sounds like that's a good question. Thank you for that. Yeah.
So obviously, people are working hard to figure out how to prevent these injuries, how to prevent your teenage daughter from tearing her ACL. And prevention kind of sort of works, but we have not figured out, a little bit like stem cells, we've not figured out the prescription and the dose that it needs to be. But there's some neurological and balance training that may decrease the injuries slightly, especially for those non-contact, which are 2/3 of the injuries. From a standpoint of arthritis, one of the few things that works in knee arthritis to decrease arthritis pain, doesn't cure the arthritis, but it'll decrease your pain, has been shown to be fairly straightforward thigh muscle strengthening. So there is some things that we can do in and around the knee to help prevent injury or improve pain.
So the hip is, I'm sure Heidi wants to weigh in on this. I think that would be helpful. But the hip may be a little different. I think that one of the things we do see is actually overstretching or pushing the hip to extremes of motion. And that's common in some of the environments where we're getting non-operative care for the hip. So I would agree with Rick that strengthening is probably more important. Stretching in moderation is probably healthy for the joint, but we don't want to overdo the stretching because that can irritate the hip joint and exacerbate inflammation within the joint.
So where the exercise world is going as far as what to do with any musculoskeletal disorder, particularly around a joint, is not just purely do you stretch your muscles around it, and not do you purely just isolated strengthen specific muscles, although that's helpful. It's how we control our movement. So most of the big scientists now are looking towards neuromotor control, which is Dr. Wright alluded to in some of our prevention studies. But when we see somebody, we're treating them and we're trying to not only reduce pain, but improve control of how you use it. So do my muscles fire in the right way, the right time, so that I'm stable around my joint? You got to have the right length of the muscle, which might include stretching, and you got to have the right strength. But if that's not coordinated, it doesn't matter as much as what we're finding. So we have some, I'm involved in some of those in low back pain trials that are in collaboration with the PT school here at WashU that looks into that.
Great, thank you. Next question? Do we have? Yes, we have a question over here.
Dr. Prather and Dr. Bukowski, is there any benefit with myofascial release post-surgery for low back?
I can't wait for him to answer.
You're asking great questions. We're having a debate here about the...
So I'm lucky in that I work with Heidi and her partners. So the answer is yes, and I'll let Heidi speak more to it.
So fascia is the lining around our muscles. You think of it like saran wrap. And it's innervated by a different part of the nervous system than the muscle is itself. So when you ask your muscle, your bicep, to contract, you use your peripheral nervous system and your muscle contracts. But when you tell your heart to beat and your lungs to go up and down, you're not actually telling them that. Your sympathetic nervous system is doing that. The fascial system is densely innervated by that system. So if you have a muscle problem or you have a back surgery and you have to recover from all that tissue. Some of the tissue that's quite painful, in fact, you think something might be broken, it's so painful, can be the fascia. The beauty of us getting to collaborate is we get to talk about those things. And at Barnes-West County Hospital, you have the highest trained manual or myofascial manipulation specialists. They're all medical massage therapists. We've brought in an expert from Italy who's trained them. And they have a very special technique that it's not just come here all the time, it's can we get rid of this long term. So I think Dr. Wallowski will go along with me that it can be extremely helpful, and it's really good for people that have that component of pain.
Terrific. And a question, okay, yeah, I'm sorry.
Hi, yeah, as a female athlete with knee problems, I was told a lot that it was, I was training like a man, but that didn't account for my hips. Is that why there's so many ACL problems? Do you have any reason why female athletes have more of these problems?
So like many things in life, it's multifactorial as best we can tell. It's hormonal, it's anatomic, and it's muscle control. If you, and one of the things and where prevention can help is that if you look at a man jumping off a 2.5 foot high block, and you look at a woman jumping off the same block, we land differently. We don't really understand why, but you can do jump training, things like that. But we can't specifically say the exact reason women tear at a higher rate. It's been, as you can imagine, being researched incredibly thoroughly, but it's not just one single factor. It's narrow notch, wide hips, different muscle control, hormonal, a lot of different things. So you can't just put your finger on one single problem.
Okay, great. We had a question here in the front.
Okay.
I'm sorry. Let's have the question in the front, and we'll get in the back in a second. Yeah.
Yeah, that'd be great.
Yes, please.
How long can you expect a knee replacement to last?
Okay, so the question was, how long can you expect a knee replacement to last? John, I think that's for you.
I guess we can, so I think, so it's a great question. I think assuming we don't have an early problem with the knee, I think about 20 years is a reasonable estimate that the knee will last 20 years. There have been some major breakthroughs in the past 15 years, specifically with regards to hip replacement. And the plastics that were introduced 15 years ago in hip replacement have been extremely effective in terms of not wearing like traditional plastics have. So for hip replacements, I tell my patients 20 years probably for sure, and likely 30 years. Rick also does a lot of knee replacement surgery. I guess my general answer would be about 20 years. Certainly they can last longer than that though.
Yeah, I would say I tell my patients 90% will last 20 to 25 years. A lot of physicians will throw out, oh, it'll last you 10 years. And I think it's a little bit of a cop-out so that they don't set the bar too high. But if you really critically look at the literature, like John said, I think you can reliably, not everyone's going to get, 10% aren't going to get there. But with modern techniques, the results are really pretty spectacular.
Yeah, I just want to, yeah.
Right? If you're starting now to get the knee replacements, they'll be much better than
those are 20-year-old studies, so I think that we're banking on 20-year-old studies and hoping that they do even better.
And then just follow up on that, which a question that you might have is, does it make a difference who does your hip or knee replacement, Dr. Cleese? Now, I know that it makes a difference if they see you. But no, does it really, does it make a difference? Is there technical aspects of that? Now, you showed a very complex case. The kind of case that Dr. Cleese showed, by the way, brought those hips down, there's not very many surgeons in the world that would be able to do that. So, if you have that kind of problem, it's standard hip replacement, does it make a difference?
I think it's a little bit of a loaded question, Regis, but it's like anything else in life. I think whether it's doing surgery or playing sports or whatnot, but if you do a real lot of it, you tend to be better at it. And so, and studies have clearly shown that hip and knee replacements that are done at high volume centers, the results are better than hip and knee replacements that are done at low volume centers or by low volume surgeons. So that's not to criticize low volume institutions or surgeons, but clear, the data is clear.
Yeah.
That high volume, sophisticated programs, the results are better.
And just one follow-up, Dr. Cleese showed, the length of stay. Our length of stay, there's a national institution called Vizient that looks at performance at centers across the country and looks at length of stay and other things. It includes Hospital for Special Surgery, Mayo Clinic, all those places you see advertisements for. We're number one. The hip and knee arthroplasty program at Barnes-Jewish Hospital is actually, and the Vizient program is ranked number one in the United States. So it's really remarkable what Dr. Cleese and the team has done around that. So and I think, unfortunately, I'm told we can have one more question, and there's a question in the back. I'm sorry, and so yes, please.
Dr. Wright, you did not know that I was going to be here tonight, but you operated on me on January 26, 2018. I had the great good fortune in having you do that. So I was one of your 200 projected patients this year who would get surgery from. I have friends in Florida, Chicago. They want to know who this guy was because the day after I was at a 5.5 on pain, and 2 days later 1.5, and didn't need hardly any oxycodone. I have so far, and I'm not trying to be humorous, but I have not given him your name or your phone number or anything. Should I recommend you or should I keep it a secret? It seems with the studies and everything, you're really a busy guy. But seriously, I haven't told him. I said, well, I might give you his name, I might not. But I'm kind of jealously guarding your name.
Well, thank you. That's a real tribute. And but my work ended January 26th. You've done everything in the recovery since then, so it's always a credit. The rehab is always as or more important than the surgery that we do. So it's always a team. And we got to keep going. So give out the name.
Yeah.
We always take new patients.
And I know there's many. Yeah, I know there's many more questions. I'm told we're going to have dinner. We're going to try to stay. I think we'll stay for. I'm going to be staying for dinner. Hopefully, other panel members can stay for dinner. And I understand. This is a group that's highly recruited. None of you are going anywhere anyways. So they'll be around St. Louis for many years. So we'll have a chance to ask them questions over time. And but it's been wonderful to have the opportunity to share our program with you. It's exciting to go to work every day with these colleagues and others that we have. We have 72 faculty in the Department of Orthopedics now, and each one really serves the mission in a very special way. So thank you for coming and for your support. And again, I thank the auxiliary and the board for allowing us to be here tonight. Thank you so much.